Good morning, my opponents, judges, and everyone. Today we're going to present our study, Computational Design of Anti-TFR, Anti-Base 1 Bispecific SCFE for Optimized Drug Delivery in Alzheimer's Disease. Next. So the current therapies in Alzheimer's disease, mostly consisting of conventional antibodies, are causing ARIA or amyloid-related imaging abnormalities, presenting stroke-like symptoms due to the rip of the blood-brain barrier, especially with people with high genetic predispositions. Base 1 is the hallmark of Alzheimer's disease. It works by cleaving precursor protein and releasing toxic beta amyloid into the brain. Now we're building small-size bispecific SCFEs to deliver treatments through the transferrin receptor in the blood-brain barrier. Next, please. So we gathered sequences of anti-TFR and anti-base 1. Then we predicted the variant fragments of these two arms. We constructed those into one construct. Then we 3D modeled with AlphaFold 3D. We also verified the quality using Verified 3D score, error score, and Ramachandran plot. We also did protein-protein docking between these two constructs and it to the transferrin receptor and to the base 1 itself. And then we will do molecular dynamics and predict the ADMET. Next. So the modeling score here shows that every of the score are under 2 angstrom, meaning that the error is very low, and the confidence level of the structure construct itself is very high confidence, and the interface context and the residue level from the results of molecular docking shows low to affinity moderate, exactly what we targeted. Next. And this is the 3D structure quality, where we did several tests to ensure that our construct is well designed. And all of these scores, all of these plots show score above 80 or even 90%. Next. So the conclusion of our construct is that it's stereochemically visible and developable, and it can further lead to a more computational analysis. And for future research, we will conjugate our construct with MMP2-containing PEG-related liposome to elevate mechanism of actions by not only inhibiting the base 1, but also targeting the toxic protein that has been built up in Alzheimer's disease patients. Thank you.
Okay, thank you for your presentation. We will now have a 6-minute debate. Okay, so you will be and ask questions for 30 seconds and your time starts.
Okay, thank you. So my first question, this is a good presentation, but regarding the base 1, right? Base 1 that you target as your drug, could you explain why you targeted this base 1? Because we know that this is already clinical, it is already not passes the clinical trial, this mechanism. Thank you.
Yeah, actually that is our purpose of study, because the previous clinical trials, the anti-base 1 never passed the clinical trial. That's why we want to design a smaller part of antibody. That's why we want to design SCFV, which is more smaller.
Yeah, but instead, either the small or big, the mechanism of this anti-base 1 is similar with base 1 inhibitor. They will block the base 1. The reason why this clinical trial is not passes, because if you block this base 1, it will be affect to the physiological normal of the brain, like learning and memory function, and this is the reason.
Thank you. We understand that base 1 is also involved in the regulation and homeostasis of the brain, but on Alzheimer's disease patients, especially when they have the genetic predisposition to have higher beta amyloid toxic protein production in their brain, their base 1 level will be much higher than the normal person's brain. So we're targeting that, and we're also conducting this concurrently with genetic testing, so to make sure that these people that get this treatment has the risk of Alzheimer's disease.
Okay, thank you for the opportunity. Even if you target base 1, with a global source identity of 52% between base 1 and base 2, it would be very hard for you to specifically target for base 1 only. Then it will affect base 2 with BAC2, which is also regulating brain's function. And where you target base 1, you will 80% there is an 80% chance that you will also target base 2. How will you compensate for that?
Yeah, from our computational model, we made it very specific that we built an anti-base one, specifically SCFVs, for the research whether it will affect base 2 as well. There also there needs to be further research, of course, but it's outside of the scope of our study right now, and we're focusing only on base 1, which is the hallmark of Alzheimer's disease itself that we know of.
Yeah, thank you. You mentioned of that. Statement, because you in your study you didn't mention any molecular docking results of your study that to determine this is specifically on to base 1, or it could be affect also to base 2, like my colleagues mentioned.
Okay. We apologize for not showing it. It's actually in the slide, but it's hidden because it's only a bunch of scores with negatives and positives. And we also actually show the interface context and residues, which we have shown before in the slide. There is the heat map, where we specifically wanted to be low to affinity binding, low to moderate affinity, to make sure that those constructs can easily be released into the brain.
So you just did it, not already.
We already did
But
it.
you're not performing the result.
We already gave the heat map, actually, on the slide.
Yeah, but it's not molecular docking result.
Oh, it's the visualization of the molecular docking.
So you already performed with the RMSD result also?
Yes.
Did you validate it?
Yeah.
Okay, which native ligand you use?
Sorry?
The native ligand you use.
The native ligand.
Native ligand. Because to redocking it, you need you validate it, you need the native ligand, right?
Oh, there are several ligands and residues that are involved in the molecular docking itself. I couldn't mention there are so many amino acid residues that are involved within this docking.
Okay, I will another question that you mentioned in the title that the optimized drug delivery across BBB, but you could show us the transcytosis quantitative result, since the uptake result or efficiency transport to support that claim, because you mentioned in your title, but your data provide only the protein model quality instead of drug delivery result.
Yes, that would possibly need another wet lab analysis for us to be able to analyze the transcriptomics and the gene expression of our construct. Basically, now we're building computational models so that we are only selecting a few candidates before getting into the wet lab, before spending resources on the wet lab. So we're getting the best candidates computationally first before getting into the wet lab.
And also, you only validate the structure in this result, right? Validate the structure, but in your conclusion, you mentioned its biological function and also its drug delivery result. Do you think this is the strong result to conclude that? But why you not mention only prediction instead?
Oh, actually, we always mention that it is predicted, the result of prediction.
I didn't saw it in your conclusion.
Oh,
The prediction word.
In our conclusion, we mentioned that it's stereochemically visible and developable, meaning that it has the scores we needed during the molecular docking and the binding affinity to get the score that we need, and we can predict and extrapolate from that it might be having great results in.
We'll now have a 1-minute break to prepare for the next. Can we check the presentation, please? Is this the correct file? Is this the correct file?
It should be yes.
You still have around 40
Oh, okay.
break. Okay, the break is over. If you guys are ready, your time starts now.
Okay, my name is Haryanto and my colleague Romi. Okay, good morning, ladies and gentlemen. My name is Arianto and my colleague Romy. Today we present about the emergence of colistin resistance and heteroresistance in Acinetobacter baumannii, a sequential time kill and molecular characterization study. Next. This antibiotic is a polymyxin class. This has mechanisms binding to lipopolysaccharide and causing cell lysis of bacteria. This antibiotic is used as a last resort drug to overcome infection caused by multi-drug resistant gram-negative bacteria. But since 2000s, the colistin-resistant isolates of Acinetobacter baumannii was firstly reported, and so imagine that we will pass the era before antibiotic penicillin was founded. Next. That's why the objectives of our studies are to evaluate the bactericidal activity of colistin and polymyxin B and their roles in the emergence of resistance, including heteroresistance and adaptive resistance, and to characterize genetic alteration associated with this antibiotic resistance. We use 2 clinical isolates from the same patient after this patient get colistin treatments X days. The susceptible one mentioned as col S and the resistant one mentioned as col R, and we determine the difference between these 2 isolates by DNA sequencing, and we perform the sequential time kill after. Next. So we found that between the susceptible and resistant one, there is a mutation in PMRB gene leading to the LPS modification and leading to the high level colistin resistance. Next. And then we do the in vitro study. We perform the first time kill and the first time kill and the second time kill, and we found that col S, susceptible one, could develop to step-by-step resistance under colistin pressure, but not in polymyxin B. And in the col R, the resistance strain could rigor until 16 times MIC, so in the high-level resistance, but has low adaptation in PAB. And we found that there is an overexpression in the LPXC gene that lead to the loss of LPS. And then we do the population analysis profile to identify the heteroresistance, and we found that there is a subpopulation that exists in these isolates, but they have the gene expression level. In the col R, there has PMRBC overexpression, and the subpopulation there has LPXC and LPXC, not only PMRABC. And this subpopulation, that's why this subpopulation saw the highest level resistance compared to the other strain. Next. So we conclude that E. baumannii adapts rapidly under colistin pressure with minimal adaptation to polymyxin B. And this high-level colistin resistance is dual-state process from the LPS modification and can lead to the loss of LPS. And this implication of the study, this is sequential time kill over a simple approach to discriminate different PD model structure to describe the emergence and resistance, and then we could predict and prevent the resistance. Thank you.
Thank you for the presentation. We will now have a 6-minute debate. Okay, your time starts now.
Okay, thank you for the great presentation. Why did you use Sanger sequencing, which is targeted instead of whole genome sequencing, meaning that you might targeting only the known genetics, known genes that are involved within this mechanism, instead of knowing everything that is involved within the gene, the complex genetic pathway itself?
Thank you for your concern about this. There is already established the mechanism of resistance in Acinetobacter baumannii associated with this colistin, with antibiotic. So there is only 2 mechanisms that already developed by this bacteria, loss of LPS and LPS modification, because this is only the part of the bacteria that bind with this antibiotic. So there is already founded also the mechanism by PMRB C gene or LPXC, LPXA and C. So only these 2 genes that we do the Sanger sequencing, and we found that there's only mutation in PMRB gene.
Yeah, but you cannot necessarily know every mutation that happens to other genes within that same allele. So you cannot necessarily know the genetic changes within the same allele, let's say, or the genetic section of that bacteria, because you only use targeted sequencing instead of doing the whole genome sequencing. So you don't know whether other genetics can have implications on the process of the mutation itself.
We don't need that. Actually, we don't need to know the other gene, because we already specific know this gene that's concerned to this resistance. So that's why we didn't need to perform the whole genome sequencing. We target the gene. We already target the gene, and we perform these 7 genes. We already know. And the next step, we trying to develop the model, PD model, based on the TKC results. So this only the main message of the study. We didn't want to know the mechanism of the resistance, but we would like to develop the PD model.
Okay, the second question is, how can you be so sure stated that polymyxin pressure could alter gene expression? Because there's maybe already subgroup that have resistance in there. And you also didn't take like the time longitudinal sample. So you cannot say that call resistant emerge after call sensitive.
Emerges after?
Call resistant emerge after call sensitive, call S.
Sensitive one. Okay. The first question I would like to answer. The polymyxin B, they has low adaptation in polymyxin B, because you asked the polymyxin B, but they could develop step-by-step resistance in colistin. And we analyze this resistance, this adaptive resistance, based on their gene overexpression level. Then we found there is LPXC overexpression. So if you ask how you predict the mechanism, we didn't know the mechanism because we didn't do that.
Okay. Then why did you choose to use reverse RT-qPCR instead of RNA-seq? Since you mentioned in your conclusion that there is a dual genetic mechanism. So transcriptional level, it doesn't necessarily translate to structural changes. This is also needs to be addressed later. But why did you use RT-qPCR instead of RNA sequencing? And you also do generalization of evolution that is happening within your culture.
The conclusion of the mechanism, the dual-step process that we mentioned, is already mentioned in previous study. We do this study based on this result. So that's why we confirm this mechanism is already established in the Acinetobacter baumannii. In the study, we try to develop the PD model. That's why we mentioned time kill study. And we try to challenge the bacteria by various concentration. And then after we get the isolate that could regrow in this adaptor resistant selection, we isolate the gene. And why we do the RT-qPCR? Because we want to know the expression level quantitatively. That's the main message.
Why didn't you use RNA sequencing, which would be more giving you a higher perspective on every transcriptional
because
level?
Because that's not our study. Our study is to develop the PD model that I mentioned. This is the adaptive resistant, heteroresistant that we found in the subpopulation, or this is the resistance since beginning.
Yeah, but I think if you use RNA sequencing, it could give you a higher implication of every every genes involved within your study.
Yeah, but we didn't to know the. This is not our study. The main study of our study. We only want to know the gene related to the colistin resistance, which is genes.
RNA sequencing is also analyzing your gene only. That's transcriptomic level actually.
Yeah, but this specific signal sequencing is really specific, cheaper, and it's related what we want. Yeah.
Okay. So did you do another round of validation when you mentioned that there's this transcriptional level translates to this antibiotic resistance? But did you do gel electrophoresis to really make sure the protein is exactly made, or mass spectrophotometry to validate your study further to really know that the protein does exist instead of only genetic level transcription?
Yeah, actually we also do the MS to confirm that if there is a loss of LPS or the LPS modification, and we perform in the further study. That's why the isolate that we got, we not only we perform the genes sequencing, we also want to prove if there is also the loss of LPS or the modification of LPS by MS study, and we already performed that, and it's published in our in different article.
Okay, thank you. Time is up. So we will wait for around 10 seconds to make sure the score is final. on the right is D111. Okay, good morning and welcome everyone. My name is Sarah. I'm the referee. This is Salma, the runner, and we also have our judges Stephanie and Bu Adriani. So first of all, we'll do a coin toss. The winner will decide whether they want to go first or second. The first team will present for 3 minutes, followed by a 6-minute debate where the opposing team can ask questions for 30 seconds and the defending team will respond in 1 minute. After the 6-minute debate, we will have a 1-minute break for the transition to the next team, and then we will repeat the process for the second team. I will be strict with the time, so please use your time well. And don't forget to kind of use your phone, your laptops, just your notes, and the match is fully in English. Also, a little reminder, for the opposing team, please do not ask for clarity, but directly challenge the other team. And everyone needs to participate in the debate. Do you understand that rule?
Yes.
Okay. Okay, so this team can choose heads or tails? Tails. You guys want to go first or second?
Yeah, we'll go.
First. Okay, so please prepare the presentation for the ABC. This is the correct class. If you are ready, your time starts now.
Okay, so everyone around the world, billions of people have died from tuberculosis, and WHO has recommended the use of whole genome sequencing and new regimens called PPALM, or bedaquiline, protomanid, linezolid, and monoxifloxacin. Now, the challenge is that the whole genome sequencing can produce many variants, right? And to predict which variants that has higher associations with drug resistance and how to validate them requires billions of dollars of wet lab settings and experiments and a longer time. So here we establish a computational pipelines using protein modeling, whole genome sequencing, retrieval, and data from WHO mutation catalog, and we analyze using molecular docking and dynamic simulations, and then we see the pattern, compare between the resistant strain and the wild type. Also, we compared with the phenotypic resistance from the WHO reference database. And then we see that for the binding affinity from most all of the mutant strain has reduced in the binding affinity, while the RMSF show for bedaquiline resistant strains at 1.2 angstrom indicates a strong chance of drug resistance. So we can see that this method can be used for other drug resistance prediction as well. And then for the comparisons between regimens, we see that there's 10 of stronger correlations that we have analyzed using two-way ANOVA that we use for validation in this study.
The implication to the clinical practice, of course, we promote rapid development of resistant tuberculosis, so we have understand and determine more rapidly identify resistant and treat a better treat of the patient of tuberculosis. So those are the key to enhance the prevention and control of tuberculosis through eliminate the widespread of tuberculosis associated with drug resistance. So therefore, with low budget surveillance through the computational screening, we can help many countries, regardless the economic social status, to success the elimination of tuberculosis. I think that's all. Thank you.
Great, thank you for the presentation. We will now have a 6-minute debate.
Okay, thank you for your question. Okay, your conclusion are based primarily on computational analysis. So what experimental evidence validates this predicted resistance mechanism? Yeah.
So the reference that we use actually from the WHO mutation catalog that's already been confirmed. So they basically do the all epidemiological tests and then analysis based on MIC data. So we train our tools to actually predict the patterns and then we analyze which bare minimum threshold that can use to predict new putative SNPs with their resistance level.
So may I know that's what kind of tools you use to predict the analysis?
We do the molecular docking using Pyrex, and then for dynamic simulation, we use CapsFlex.
I also continue the question. So because you use data sets here, right, from WGS, how did you filter these variants to guarantee that your novel mutation that identified in your model or data set are genuinely causative because of drug resistance rather than just a mere geographical noise?
Okay, thank you very much. So for Mycobacterium tuberculosis, there's actually tools we call TB profiler. So TB profiler can inform us which variants that's already been confirmed and which hasn't been confirmed. So we use those all data sets to train our tools.
So you use all data set and not filterize it?
So that's already been filtered by TB profiler. TB profiler is like a bioinformatic tool that's already been developed by other researchers as well.
And
so we validate that new SNPs.
And then you mentioned about pipeline as well. That remind me something about and you want to this be used by the clinicians, right? I mean, if you use in silicon pipeline, that maybe help to predict, right? How do you assure that it will be accurate? Because it may be required to guide the decision or treatment in the hospital. How do you assure that?
Okay, so for the clinical implications, we actually help to promote a rapid development of drug resistance diagnostic tools, and we imply that if clinicians use this, that must be standardized. That's already been conducted in the next study. So in this study, we just want to explore the threshold and the pattern that can be used to predict each of the drug resistance. And for the clinics, I think it also depends on the regulations that the WHO would be recommended. So we cannot actually directly tell the clinician to use it.
So it cannot just be using in practical, right?
So it is still research. So we need more, more data.
Sure, and then I move to another thing because maybe we are integrate with your statistical here. You use two-way ANOVA on your non-linear data, right? So you apply two-way ANOVA to validate your in silicon result, but what were your distinction, like maybe independent variables that you inputted?
So we used in two-way ANOVA because we have many data from different drugs. Like we not only use beta-acylin, so we also test other drugs as well, like rifampicin for the reference, and then we would like to see the associations between the binding affinity, the RMSF, and the resistance status. So we model the resistance status as the dummy variables, 1 for resistance, 0 for no resistance. So then we use the two ANOVA to see the correlation as well.
But maybe because some of data, such as maybe SNP or the protein binding, maybe it's not linear data. So why you still try to use one-way ANOVA that usually being used to linear data?
So actually it's depend on how many variables that we want to test, and actually because we want to see the exact correlations, two-way ANOVA is more suitable for this research, and we see that we have to compare each of the variables with another variable, so it's not like independent like what you said.
Yeah. So were the assumption of normality and homogeneity of variance verified in your data set?
So we also perform descriptive tests to actually see whether the data is homogeneous. And yes, we can see that from the data that we collect and then we model, it results in the very distinct model between the binding affinity data and the RMSF. So all data is homogeneous. All data are homogeneous in the study.
Oh, the data is homogeneous. So you don't have any extreme outliers there. Usually data have outliers. And what did you do with the outliers there in your data set?
Okay, so there's no outliers because the exact actually the binding affinity in the RMSF can be actually clustered. So in this case, we not test all like us together, but we separate each drug for every resistance level or for resistance status. For example, bedaquiline we test only bedaquiline, and then for rifampicin we test only for rifampicin.
Okay, thank you. The time is up. We'll now have a 1-minute break to prepare for the next team. Is this the correct presentation slide?
Yes, it's correct. Back to the first slide, please. Okay. Yeah, this is.
Okay, you will now have 3 minutes to present your slides. So if you are ready, your time starts now.
Okay. Yes, we are ready. Good morning, judges and fellow researchers. My name is Umuditi Aliana, and this is my partner, Muhammad Regiono. We want to present our study on comparison of nutritional status before and after chatbot-assisted dietetic nutrition care implementation in pediatric oncology patient. This presentation or research is the combination of expertise from nutrition, health informatics, and artificial intelligence. Slide, please. Okay, can you imagine that every year 400,000 children are diagnosed with cancer? So when they get cancer, there are nutritional vulnerability such as poor intake and then changes in metabolics and also the gastrointestinal symptoms such as nausea and vomiting. Therefore, they have a risk of malnutrition and then maybe have a treatment tolerance and then long recovery process and other clinical outcomes. That's why we create chatbot to assist dietitian to create a nutritional monitoring to help the dietitian to early identification of malnutrition risk and also help the dietitian to lead the intervention and help clinical decision support. Next, please. So this is the research gap here. That's why we created from the medical record from Saiful Anwar General Hospital, and then initially we have 158, and then finally we analyzed 101 medical record of patient into 2 months. The first month 51, and then the second month 50. What we assess is the primary outcome was the nutrition status, weight for age, height for age, weight for height, and BMI for age. Also, we assessed the related clinical outcome. It was hospital length of stay. Next. And then let me highlight the key finding of our study. The first, from all the medical record, most of the patients have normal nutrition status. And then the second, in the stunting group, there were decreased the number of stunting patients from 17.6 to 6% in the second month. And then the third, it showed that chatbot assisted dietetic nutrition care didn't significantly change the overall nutrition status during the study period. And the next, please. We will do the primary study this year by longer study, longer follow-up, and also we increase the number of patients that we assess. We also will assess directly to the patient and assess by primary data. Thank you. We are very welcome to feedback and questions.
Presentation. We will now have a 6-minute debate. Your time starts now.
Okay. Maybe I have like several concern, and also it could be I need confirmation. First, I noticed that the setting in the study is hospital, right? And then, however, the kind of the interventions is quite good, and is quite good implementation and test in a community.
I'm unclear with the question. So do you ask me why it is in the hospital rather than in community? Do you mean? So why we start with the hospital, because this is the chatbot that will help the dietitians to intervention in the patient. So in the community, like primary data, there are no like oncology patient there. Oncology patient usually will be referred to the hospital because they will have a longer treatments. That's why we just use the hospital, because we just want to help dietitian in the hospital rather than the nutritionist and the primary care like puskesmas.
I get it.
We add we add the chatbot. We created from scratch from zero based on medical record. So this will be the fact, the data. So we generate the data, right?
Okay. Continue with the same question. However, I believe this a kind of this intervention chatbot especially is more good implement in a community, because I noticed that the focus of the population is the children with the cancer. Most of them know that cancer patients require providing care in a hospital more than the hospital.
So this why the chatbot cannot replace with the dietitian diagnosis. So that's just the support tools to dietitian get the fact, because the data from the WHO and Minister of Health. So we use the RAG framework. So that will be get the real data from WHO and Minister of Health. So
Yeah, I think.
Yeah, I will answer more. Yeah, because in pediatric cancer or kids with cancer, they have longer treatment in hospital rather than in puskesmas or primary care. And then because they will live more time in the hospital rather than in the puskesmas. That's why we just use the medical record in the hospital, because maybe if we find or look at the puskesmas, there will be no patient with cancer.
Yeah, I'm very understand with this, with your objective, but I think it's very meaningful if the chatbot is implemented in community. I would strongly would disrespectfully disagree that the children with the cancer more require hospital, because in the pack of the data, because my research also in an oncologist, the children with the cancer more require
Yeah, because this chatbot actually not for the parents. This chatbot is for dietitian. That's why it cannot be in the community. This chatbot is to help dietitian in the hospital to more efficient to decide which intervention or diet, how much the food that should be given, and the other specific macronutrients. So this is not for parents. That's why it cannot be applied to just us.
Okay.
Yeah,
So sorry.
something like that.
Okay, maybe moving to the my concern that need to the clarification from you. I think the first I suddenly find the stunting in the middle of the your slide, and maybe I more suggest to you only say the in a form of nutritional status rather than the stunting, because the stunting is more complex to diagnose, because we need like the other things rather than just the weight or height.
Yeah. Yeah. That's why we use medical record there, because stunting is not just in 1 day or 2 days and multifactorial. That's why we use medical record to track only the stunted group in the first implementation, in the first month, sorry, and then the second month. And then also why you just use nutritional status, because stunting is the hot issue here. That's why from all the pediatric patient, we took stunting to be sample there.
Okay, so thank you very much. So in each of the patients that might be used like different drugs. And for example, those treatments also affects the nutritional status of the patient, and that could increase the bias. And what is the statistical methods that you use to validate those confounding factors, and how can you be sure that there is no synergistic or antagonistic effect that could reduce the validity of your result?
Yes, because it is just baseline, so we didn't consider the treatment or something. We just want to know how is the medical record in Saiful Anwar, and then we just collected it first, and then take the nutrition status there. This, yeah.
The time is up. We will now have a 1-minute break to prepare for the next team. I'm sorry, this is the last round. Sorry. So, okay, we'll wait around 10 seconds to make sure the scores are final. Okay, so we have a tie, so we will now do a tiebreaker. Operator, can you set the time for 2 minutes? Yeah, so we'll do a tiebreaker. In the first 2 minutes, the opposing team will be the opponent, so you can ask questions. And then after that, we'll have another 2 minutes for the other team to ask questions. Timer ready? 2 minutes. So this team will first be the opponent. Your time. Okay, your time starts now.
So that's I want to know about your statistical. You use the to analyze the data. So what kind the statistical you use the analytical data. So what that?
So first, we validate the binding affinity and the RMSF associations using the normal and distribution homogeneity test first to validate whether we can further analyze using descriptical tests and then using the inferential statistical models. Here we want to see the correlations, right? So we use the two-way ANOVA for the test, and then because we cannot use the post hoc test, we use the correlation test from the two-way ANOVA to exactly see whether they can be statistically significant.
So
also we use the PCA to analyze the pattern.
So how did you verify that the assumptions of your statistical tests were satisfied?
So we use the confirmed database, sir. We use
Yeah.
the WHO database that's already been confirmed globally. So all data were verified in the study. We used to train our tools to understand the pattern that will differentiate between resistance and the non-resistant strain. Is that answer the questions?
Yeah.
Thank you.
Oh, yeah. Maybe because I'm clinician as well in the hospital, I want to know how do you can distinguish any biological meaningful in your data and resistant drugs to the medicine in practice.
Thank you very much. So basically, all the doctors who treat tuberculosis, especially drug-resistant strain, has a huge challenge in determining what regimens can be used, because there is a specific diagnostic tools available for gene expert, for example. This only predict only one line, which is the rifampicin and then isoniazid. Then we need to culture the bacteria and do the MGTST test, which costs billions of rupiah. So this would be very effective if we use this model to actually help the clinician in the future.
Okay, thank you. We'll now have another 2-minute debate. So this team will be the opposing.
Okay.
Your time starts now.
Come back to the question related to compounding. I think because I also the clinicians, in the medical record, you mentioned that in the medical record is insufficient to collecting the meaningful data clinically. The first that I have to clarify that in the medical records, there are a lot of data that you can explore confoundings related to children with the cancer, especially. You mentioned earlier before in the slide, in the introduction section, about the... Yeah.
I didn't get the question yet, but we know that there are so many data that we get, and then that's why we choose just one that very has strong correlation, and then because the medicine is so similar there, we cannot get any significant difference from the cancer treatment between or among the pediatric patient. That's why we just choose which one is the most significant, which one is the most meaningful to be presented in this forum.
Okay, so I think I have to recommend you to put in several variables that I think is meaningfully to put. First, related the cancer stage, of course, is available in the medical record, and then the infectious status, comorbid, treatment regimen, because you mentioned earlier before that the nutritional status are also related with the treatment-related toxicity, right? Because kind of regimen.
Yeah. I have advisor from the pediatric oncology dietitian with more than 10 years experience. There is no clinical stage of the pediatric oncology patient. They decide from the morphology and treatment. And then, in this second year, we also put the pharmacology, clinical treatment, and also we consider food intake.
Yeah. I think, oh, sure.
Okay, so we'll wait around 10 seconds to make sure the scores are finalized. Okay, so these are the final scores. For D0111, your score is 25, and for D0083, your score is 27. So congratulations.
Congratulations.
Both of the team saw the very high standard of the debate, both of the attacker and also defender. So it's not, I think it's not have to be just so the mark, but also have to appreciate your effort to be in this stage. So good luck for the next round for the winner. But I think that both of the team has the very good result, and also the background is very strong. So just semangat for Indonesia, better Indonesia. Thank you so much.
Thank you for your time. Kongres.
You will have to go to Region 1. Your match will start soon, but you will have a 10 minutes break. So your opponents will be team. Oh, not yet. So your opponents is not yet decided.
Sini aja. Di situ ya, di situ ya.
Di sini aja.
Boleh liatin dojonya, Mas, boleh liatin dojonya. Boleh minta tolong. Ya, liatin dojonya. Oke, referee juga ya. Iya, kelihatan ini yang genomik dojonya. Dojonya kelihatan.
Matiin dulu ya.
Oh, tapi ininya, desainnya, dojonya, nggak apa-apa.
Oh, dojo ya.
Pinggir aja.
Minggir-minggir sama minggir.
Oke. Ya, nggak apa-apa.
Biasa
Siapa yang belum? Mbak, ikut Mbak. Oh, agak tengah Mbak, di sini. Jadi, bisa asal tulisan aja.
Masnya serong. Geser ke sini, sorry. Geser ke sini lagi. Geser. Lihat ke sini semua ya.
Gimana gayanya? Apa? Terserah.
Lucu.
Korea.
Kamera semua 1, 2, 3. Lagi. 1, 2, 3. Ketiga ya. Satu, dua, tiga. Oke.
Oke,
Terima kasih Bu. Dari Macung, dari Malang. Iya.
Pak
UI.
Pak Uyun, Unpad dan UI.
Iya.
Brawijaya dosen. Oh, mahasiswa.
Dosen.
Mahasiswa. Oke, kalau